complications. First, طبعا these are just يعني for fun the difference between the previous or the traditional operative room which was called operative theater. دايما احنا بنسمع عن كلمه operative theater. ما كناش عارفين why it's called theater. Theater لان it was allowed for the audience to be present in the operative room. يعني even all of the medical students, even the relatives for the patient or anyone can pass in the street side the hospital can attend. There is no problem at all, and for sure we don't care about the infection control or even about the anesthesia. يعني most of the operation were conducted while the patient is fully conscious. فطبعا it was very يعني ايه حاجه مأساوية فعلا. And طبعا that due to development we have a current or modern operative. طيب let's talk about thyroidectomy. What are the different indications to perform thyroidectomy? مثلا let's كده revise what about different diseases that you know about on the thyroid disease. مثلا Sami goiter. Is it indication for thyroidectomy? لا ليه؟ One of the options. What is the treatment of Sami goiter? Conservative, medical treatment by hydroxyl, surgery. السرير اهو حتى قعدنا ساعتها نتكلم total والسب total and so on. So we have surgery in the Sami goiter if it's indicated. But is it considered to be indicated in all cases of Sami goiter? No, we have a certain indications like failure of medical treatment. Okay. Retrosterile goiter, excellent. Large size goiter, and so we have a bad cosmetic appearance, or if we have pressure manifestation, like the patient become dizzy, and so we have a compression sarcopenia. These are absolute indications for performing thyroidectomy goiter. Type. It's also the same part for the colloid goiter. We have a colloid goiter, which is huge in size and performing bad cosmetic appearance or compression manifestation. This indication for thyroidectomy. That means toxic goiter when we are in need to perform thyroidectomy. If the toxic nodular goiter, it's the main line. Rapes, if we have failure of medical treatment after 18 months. Toxic nodule, if the patient is less than 45 years. Or if we have hereditary thyroid nodule, or if we have any type of neoplasia. And inshallah in the next lecture we will talk about different types of neoplasias. So either benign or malignant tumor inside the thyroid is a pure indication for thyroidectomy. Type. What are the different types of thyroidectomy? You know some of them. Total, subtotal, hemithyroid. And these are the most common. So, let's say that this is the thyroid gland in a cross section. What's the meaning of total thyroidectomy? I remove the whole gland, يعني both lateral thyroid lobes, the isthmus and the pyramidal lobe, all of them will be removed. But what's the meaning of subtotal? يعني I remove the whole except the postomedial. Why we are preserving the postomedial aspect? To protect the recurrent laryngeal nerve and the parathyroid glands. Okay? So now you are performing thyroidectomy, and so you should ligate all of the blood vessels like superior thyroid, middle thyroid, and inferior thyroid. How the vascularity of the postomedial aspect of the lateral lobe will be preserved? Accessory, tracheal, and esophageal branches, which will reach to the postomedial aspect through peristalsis. Then we have hemithyroidectomy, which was previously called lobectomy. But lobectomy is a wrong name. Lobectomy means that I will remove just one lobe. Like actually we are not removing one lobe. I mean, to remove this lobe only, and I can't remove this lobe and keeping this part. The minimum is to remove the affected lobe together with the isthmus till I'm reaching to the contralateral lobe. And so this is called hemithyroidectomy. Okay, so give me one example for diseases which is treated by hemithyroidectomy. Less than 45. Okay, type. These are the three main types. Then we have different additional types that you can know, like مثلا في حاجة اسمها near total, at which we are removing the most bulk of the thyroid, leaving a small, very small, little tissues over the recurrent laryngeal nerve to prevent its injury. We have Dunhill procedure, at which we are performing total thyroidectomy on one loop and subtotal on the other loop, and we have the completion thyroidectomy. What means completion thyroidectomy? Let's say that we have solitary thyroid tube on this side, and the patient is athyroid, and so what's your next plan for management? And this, let's say it's 2 centimeters in size. Athyroid, solitary tube. What's the next line for investigation? Investigation. Finding. We have athyroid with solitary tube. What you are fearing from? Cancer. And so how to confirm our experience? Why needed can diagnose all of the pathology inside the thyroid gland except cancer, follicular adenoma, and carcinoma. So let's say that we have a solitary thyroid tube in this loop, and we are taking a fine needle aspiration, and fine needle aspiration told us that we have follicular cells. What's the meaning of follicular cells? يعني I can differentiate if it's follicular adenoma or follicular carcinoma. Our follicular adenoma is treated by hemithyroidectomy. Follicular carcinoma we can, we should perform total thyroidectomy, but we can't know. So we have one of two options. Let's say that you decided to perform hemithyroidectomy and send it to the histopathology. After the operation, the histopathological report reveals that we have follicular carcinoma. And so, what's your decision? I will re-enter the neck again to remove the contralateral layer. And so, this second operation is called completion therapy. And I will complete the primary step for the hemithyroid. Indications, these are the indications that we just mentioned. I think, inshallah, once you are studying thyroid gland, you should be oriented without revising all of the indications of thyroidectomy, and these are the types. We have total thyroidectomy, total thyroidectomy, which is removal of the whole gland. We have the subtotal thyroidectomy, which is another alternative method for total thyroidectomy in benign thyroid conditions, but bilateral pathology, like Graves, like nodular goiter, like colloid goiter, like again toxic nodular goiter, and so on. Thyroid lobectomy or become replaced by hemithyroidectomy, at which we are removing the thyroid lobe together with the isthmus, and so this is the hemithyroidectomy together with Dunhill, which is total on one side, subtotal on the other side, and completion thyroidectomy, which is removing of the remaining lobe inside the thyroid. طبعا surgical anatomy, there is no need back to revise. What about the relations for the thyroid? Superficial or anterolateral relations? Skin, fascia, platysma, sternomastoid, 3 strap muscles. Sternum, thyroid, hyoid. تمام؟ طيب, what about the median relations? Up and down, up. Right? Superior range. Down. Okay. Esophagus, recurrent range. Posterior relations. Containing internal jugular. Vagus, stomach chain. Parathyroid type. What about the arterial supply? Arteries, veins, lymphatic. Arteries. Superior thyroid. Inferior thyroid. Thyroid artery may be absent, but interstitial or tracheal branches. Veins. Superior thyroid with the superior thyroid. وinferior thyroid veins and middle thyroid واccessory tracheal and esophageal. طيب, these blood vessels has important relation to certain nerves. Superior thyroid vessels, external laryngeal, which is coming from superior laryngeal, is coming from وفي مع external laryngeal but still far or higher internal laryngeal. And what about the function of the external laryngeal? Purely motor to great thyroid muscle, which is responsible for creating the vocal cord, responsible for high pitch. If we have injury, also high pitch twice. Internal laryngeal, sensory, mucous membrane above the vocal cord. If we have injury, choking. Type inferior thyroid related to recurrent laryngeal nerve when it comes to injury here. Our middle thyroid may be related to non-recurrent laryngeal nerve. Yeah, أنا عارف صح. So what about the lymphatic drainage? Yes, we have a primary station, secondary station. Primary station, central cervical lymph nodes, pre-laryngeal, pre-tracheal, paratracheal, then upper and lower deep cervical lymph nodes. طيب, كويس. To perform thyroidectomy, طبعا we have different steps or principles for the technique. They are not important how to incise, what about the layers that you are dissecting and so on. لكن we are just focusing that we should perform devascularization. And the devascularization, we have a certain manner it should be respected. The first blood vessel to be ligated is the middle thyroid vein. Why the middle thyroid vein? The middle thyroid vein is the shortest blood vessel of the thyroid gland. And so if you are manipulating the thyroid gland without ligating it, it will be torn or injured, leading to bleeding and so on. And so the first vessel that you should attack is the middle thyroid, followed by superior thyroid, followed by lastly the inferior thyroid. While you are ligating the superior thyroid, you should ligate it very near to the gland or even within the gland. Leave. Let's say that this is the thyroid gland. What is the artery or vessel which is coming from above? Superior thyroid artery and superior thyroid vein. And what is the nerve which is accompanied with? External laryngeal, which is coming from superior laryngeal. Okay, and these are. So, when you are ligating superior thyroid artery, it should be ligated very near to the gland to avoid the injury of external laryngeal, and they are accompanying each other and very close to each other. Once we are reaching the upper pool of the left of the lateral thyroid lobe, the superior laryngeal will go more medial towards the larynx, while the superior thyroid artery will continue to the upper pool. And so, to be sure that you are not ligating superior external laryngeal, ligate superior thyroid artery very near or even within the gland itself. Right. While you are ligating, what is the first vessel to be ligated? Middle thyroid. While you are ligating the inferior thyroid vessels, we have a very important nerve related to the terminal branch, which is recurrent laryngeal nerve, passes within the branches and then go upward in the tracheoesophageal groove till it will reach to the larynx. What's the function of the recurrent laryngeal nerve? Motor and sensory. Sensory, mucous membrane below the vocal cords. Motor, all the entrancing muscles of the larynx. Right. So, to avoid the injury of the recurrent laryngeal nerve, we have one of two options: either to ligate the inferior thyroid away from the gland, or to ligate the individual branches entering the thyroid gland. And this is the most commonly currently used technique. And previously, the traditional thyroidectomy was to ligate the inferior thyroid artery while it's arising from the thyrocervical trunk. Okay, like currently we are dividing the individual branches supplying the thyroid artery to be sure that you are not injuring the recurrent laryngeal. Okay, this is the biggest nerve, giving a branch which is superior laryngeal, two branches, internal, external, and external it will be very close to the vessel which is superior thyroid artery. تمام؟ طبعا pre-operative preparation. Don't forget that we have two important aspects. Number one, don't forget to examine for the vocal cord to test for its mobility as a medical legal. And number two, if you are dealing with a toxic patient, there is no thyroidectomy for a toxic patient except after performing proper pre-operative preparation. My next question, how to perform proper pre-operative preparation? Start with carbamazole, beta blocker. What you are waiting for? Thyroid. After reaching thyroid, add Lugol's iodine. For how long? 10 days. What is the aim of the Lugol's iodine? بيسموها ايه؟ constipating the gland. يعني يخليها more firm and less vascular. And then you are performing the thyroid. This is about the technique. خلاص it's not important. Don't forget that the first branch that should be ligated is middle thyroid, followed by superior thyroid, and in the superior thyroid it should be ligated within the gland or very near to the upper part of the gland to avoid injury of external laryngeal. And for the inferior thyroid, it's very intimate to the recurrent laryngeal nerve, and so it should be either ligated away from the gland or individual branches for the gland should be ligated. Okay, the subtotal thyroidectomy at which we are keeping this part to protect for the recurrent laryngeal nerve and for the parathyroid. These removal and closure and so on. Looking now, what's about the complications? We have different complications that could occur during or after thyroidectomy. One of the major complications that it's general complication of any surgery is the hemorrhage. We have different types of operative hemorrhage. We have primary hemorrhage, reactionary hemorrhage, and secondary hemorrhage. What is the meaning of primary hemorrhage? This is the hemorrhage that occurs during the operation. And you are not oriented about the anatomy, you are not good in the anatomy, and this is catastrophic if you are a surgeon, and so you are dealing with the gland without noticing that the middle thyroid vein should be ligated before the manipulation. This is the shortest one, and so you are performing traction over the lateral thyroid loop. The middle thyroid artery become torn, leading to intraoperative bleeding. And so we have intraoperative bleeding. What's the name of this bleeding? Primary. What's the meaning of reactionary? Reactionary means the bleeding that occurs in the first 24 hours after the operation. When you are finishing your operation and you're performing proper hemostasis, there is no intraoperative bleeding at all, and then the patient becomes transformed into the recovery room or even into the ward of the post-operative state, and during the 24 hours we discover that we have hematoma or even bleeding coming from the drain. And so, what is the name of this type? Reaction. And this occurs after the operation within 24 hours. But secondary, it's delayed post-operative bleeding. Yani after about 10 days up to 2 weeks. So, what about the causes of each? Primary, it's clear that we have intraoperative vascular injury, which is not identified correctly, and so it becomes injured. And so, what do you think about the treatment? Ligation of the blood vessel. Yeah, we have a bleeder, and so you will catch it ligated, and that's all. And alhamdulillah, this is the easiest type of bleeding which could be managed. You are present inside the operative room, the neck is open, you have threads, the patient is anesthetized, and we have a bleeding. I will go towards the bleeder. You can see it during the operation, you can deal with it within the operation, and that's all. Like the problem is in the reaction. You finished, you are satisfied about your performance, your ego is very high, and all of a sudden they are calling you, there is a blood coming into the dream. This is called reactionary hemorrhage. And so, how to deal with the reactionary hemorrhage? Urgent neck re-exploration. You will bring the patient back to the operative room, open again to explore for the source of the bleeding. And this is a catastrophe. And so, what is the cause of the reactionary hemorrhage? We have one of two causes. Number one, split ligature. يعني you are oriented that you should perform proper devascularization before performing thyroidectomy, and so you are ligating middle thyroid, you are ligating superior thyroid, you are ligating the inferior thyroid and the renal thyroid gland. But your lecture for these blood vessels was not properly secured. It's loose, and so it's enough to perform hemostasis during the operation. Like after the operation and during the increase of the blood pressure of the patient and during sleeping, all of the blood pressure is low. And so with the recovery from the anesthetic agent and due to the pain and so on, the blood pressure will be increased. And so it can lead to perform slippage of the ligature. So this is one of the causes of reactionary. Or let's say that you are performing lecture very well, you are performing technique very well, but we have multiple unnamed blood vessels that you are dealing with during the operation. We are not ligating every individual blood vessel. We are performing like cautery, okay? And so this cautery is cauterizing all of the minute blood vessels, dependent on fibrosis of these blood vessels or making microthrombi inside it. And so, let's say that we have a certain blood vessel which is not ligated, but it becomes blocked by the presence of intraoperative thrombus. And the blood pressure is low, and so this thrombus is stable in its side. Once the patient is regaining his conscious level, and due to the pain and due to increase of the blood pressure, we will have dislodgement of this thrombus, leading to reactionary hemorrhage. Okay? So, what is the treatment? Urgent re-exploration again. By the way, if we have a hematoma, يعني not all the blood coming into the drain, we have a hematoma, the patient will suffocate due to the compression over the trachea. And if the patient is suffocating, you should open all of the suture line on the patient's bed. Don't wait till the patient becomes in the OR and anesthetized and so on. Open all the suture to prevent suffocation and then re-enter again towards the OR. Secondary hemorrhage is not common in thyroid. Secondary hemorrhage is usually due to erosion of the blood vessel, but it's delayed. Either due to presence of infection, and so we have bacterial infections that erode blood vessels, or due to presence of malignancy, a tumor which is eroding the blood vessel after about 10 days of the operation, and both of them are not commonly present in the cases of thyroid. Injury of the nearby nerves. Okay, external laryngeal nerve, where it should be protected and we should care about it while we are ligating. Superior thyroid artery, if we have injury, it will lead to loss of high pitch voice due to paralysis of Greek thyroid muscles. Internal laryngeal nerve, yes, it's a little bit far from the superior thyroid, but it could be injured and it's sensory, and so if we have injury with the internal laryngeal, it will be associated with shock. And now what about the recurrent laryngeal nerve? Recurrent laryngeal nerve is a mixed nerve, and so it has a sensory component and motor component. Sensory for mucus membrane close the vocal cords. So let's say that we have a recurrent laryngeal nerve injury, and so the sensory component become lost. Like we have intact internal laryngeal nerve. The patient will complain from any problem. Yeah, these the lines, which is lined by mucous membrane, and these the vocal cords. Advanced sensation of the mucous membrane inside the lungs is protective to prevent the aspiration and so on. And so, let's say that the recurrent laryngeal nerve, which is the sensory supply below the vocal cords, become lost. لكن the internal laryngeal, which is above the vocal cord, is still intact. And so, do we have any problem? No, we don't have. And so, the sensory component for the recurrent laryngeal nerve is not important. لكن what is the most important? Motor. هو motor part of the recurrent laryngeal nerve is responsible for all the intrinsic muscles of the larynx except the and so the recurrent laryngeal nerve is responsible for the mobility of the vocal cord. The adduction of the vocal cord and abduction of the vocal cord are the responsibility of the recurrent laryngeal nerve. طيب. Let's say that this is the vocal cord. And this is the recurrent laryngeal nerve which is supplying the vocal cord. If I'm taking a cross section in the recurrent laryngeal nerve, we will have two different types of nerve fiber inside it. Peripheral nerve fibers and central nerve fibers. The peripheral nerve fibers are responsible for the abduction of the vocal cords. The central nerve fibers are responsible for the abduction of the vocal cords. Okay? So, we can classify the recurrent laryngeal nerve injury into two types of injury. Partial and complete. Let's say that we have complete nerve injury. Complete nerve injury. And so both adductors and abductors of the vocal cords will be paralyzed. And so the vocal cords will be present midway between the adduction and abduction. And so the airway will be patent, like in both vocal cords are paralyzed, immobile. Oh, by the way, what's the function of the larynx? We have two functions. Number one, airway, صح? And number two, voice, صح? The voice box. So we have two functions, and both of them are controlled by the vocal cords. The mobility of the vocal cord will produce voice, and the abduction of the vocal cords is allowing the air entry. So, if I have complete nerve injury, and so both adductors and abductors will be paralyzed, the vocal cords will be present midway between the adduction and abduction, but paralyzed, and so the airway will be patent, like the mobility will be lost, and so it will affect the breathing or the sound. Sound or the voice. طيب, what about partial obstruction? What is partial obstruction? يعني you are using مثلا the diathermy near to the nerve, or you are ligating the nerve, لكن not transected it. And so, which fibers will be affected? The peripheral one or the central? Peripheral. Which are responsible for abduction. And so, which fibers will take the upper hand? Adduction. And so, both vocal cords will be close to each other. And so, the problem it will be in breathing. Okay, this point is clear? Yes. Let's say that you are not worried about adductor, A. B for B, breathing, partial. C for C, complete is voice. Okay? C for C, B for B. Okay? Like if you are talking scientifically, you should be oriented about this thing. Each one could be further classified into: is the injury here unilateral or bilateral? Unilateral or bilateral? Unilateral affection of breathing, it will lead to dyspnea on its exertion. What's the meaning of unilateral؟ ده معناه إن we have one vocal cord is present centrally in the midline, يعني closed, and the other one is working well. So the air entry becomes diminished, like it's still open, and so the patient will not complain except if we have exertion on the exercise or so on. Like let's say that we have bilateral partial obstruction, bilateral partial injury, striding. In both vocal cords will be adducted in the midline, closing the airway. And so it should be diagnosed initially when always the anesthesia just after finishing the thyroidectomy, while extubating the patient, he is looking by the laryngoscope to see if we have mobile vocal cords and they are mobile or not, and most importantly, they are abducted from the midline or not. If they are not abducted, he inserts the tube again and takes the patient and sends it to the ICU, and this is one of the most distressing complication for the surgeon. طيب, complete, it will affect the voice. If it's unilateral, will lead to hoarseness of voice. What's the meaning of hoarseness of voice? It's voice fatigue. It's unlike the loss of high-pitched voice. The loss of high-pitched voice يعني صوتها يبقى تخين، يبقى رجولي، تمام؟ لكن الهورسنس فويس الصوت مفتوح. يحاول يتكلم بس الصوت مفتوح رايح، تعبان. اوكي؟ طيب complete bilateral injury. aphonia. خلاص both vocal cords are paralyzed and so we will have aphonia and the patient can't talk. يبقى so again طبعا I think now it's easy for you to know what is the nerve injury for the external iliac and internal external laryngeal and internal laryngeal. الفاسكولار ماستر معايا شويه معلش. So what about the recurrent laryngeal? Recurrent laryngeal, sensory, ignore about it. Motor is responsible for all of the intrinsic muscles of the larynx except the thyroid muscle. And so all of the adductors and abductors will be affected according to the type of recurrent laryngeal injury, recurrent laryngeal nerve injury. If we have partial obstruction, it will affect the adductors, making the abductors taking the upper hand, and so we will have affection on breathing. And if we have complete transection of the nerve, so both adductors and abductors will be paralyzed, and so the airway will be open. Like in the problem, it will be in the immobility, and so it will affect the voice. If we have partial unilateral, based on exertion, partial bilateral striding, complete unilateral hoarseness voice or voice fatigue, complete bilateral aphonia. Any questions? Now we have other complications like injury of the internal jugular vein, which is passing in carotid sheath posterior to the thyroid. And so if we have injury of this vein, the problem is not only in the bleeding, the problem is in the air embolism. Then it's connected to the superior vena cava and it's surrounded by the negative pressure, and so suction of the atmospheric air could be present leading to air embolism, and it should be controlled and repaired as soon as possible. Injury of the trachea, while you are dissecting the isthmus and the pyramidal lobe from the trachea, we can have injury of the trachea, and if we have injury of the trachea, very easily it will be sutured. There is no problem anywhere. Hypocalcemia. Let's say that you are performing thyroidectomy, and after the operation, you are performing your post-operative follow-up for the patient, and you discovered that we have a very important sign present in the patient, which is perioral numbness. Perioral numbness is the first sign of hypocalcemia. And if it's not treated, it will progress to a very characteristic clinical picture, which is carpopedal spasm. Carpal spasm is a manifestation. Like before the carpal spasm, you should ask, do we have any perioral numbness or not? Then this is one of the initial manifestations of the hypocalcemia. But why we can have hypocalcemia after performing therapy? Yes, affection of the parathyroid. It's not necessary to remove. How many parathyroid glands do we have? 4. And so you shouldn't be blind enough to remove the 4 by mistake. Yeah. خلاص by mistake you remove 1, 2, 3. Like if you remove all, if you are picking it, you will not remove them. So yes, it can. Like this is not the most common. The most common is the devascularization. You will know that the parathyroid glands are supplied by the inferior thyroid artery, and we should ligate the inferior thyroid artery while we are performing thyroidectomy. خلاص you are ligating it. And so post-operative, I am expecting that the parathyroid will suffer from ischemia, and this ischemia will affect the secretion of the parathormone, and so the parathormone will decrease, and so the calcium level will decrease. This is the usual cause. Like we have different other causes. Yes, removal of the parathyroid gland, which is infrequent, and also what we call the bone hanger. This occurs if we have a long-standing thyroiditis and you are performing thyroidectomy. Let's say that we have thyroiditis for prolonged time. One of the complications of thyroiditis is the bone demineralization, يعني removal of the calcium from the bone leading to osteoporosis. Okay, so we don't have calcium for prolonged time in the bone. Once we are performing thyroidectomy, we will have what we call the bone hanger syndrome, at which the bone will absorb all of the, a large amount of the calcium present in the blood, leading to hypocalcemia. So these are the causes of hypocalcemia. What about the manifestations or clinical picture of the hypocalcemia? The initial clinical presentation is perioral numbness and then carpopedal spasm. What about the treatment? Calcium replacement. Calcium initially we are giving it parenterally. مش عارف انتوا تعرفوا او لا. طبعا calcium it should be given very slowly, not to cause cardiac arrest, and then it will be replaced by oral calcium. Thyroid crisis. طبعا all of the previous and common complications, including hemorrhage, injury of the blood vessels, injury of the nerves, طبعا tracheal injury, keloid formation, post-operative hypothyroidism, recurrent hyperthyroidism, all of these complications are frequently seen. Even personally, I saw a lot of cases for each complication, even the tracheal injury, even undetected tracheal injury and diagnosed post-operative. Is a drain, instead of bringing blood, bringing air. We found that stadiums. All of these complications are frequently seen, except, alhamdulillah, the thyroid crisis. Why the thyroid crisis become not frequently seen? Because the preoperative preparation. Once you are preparing your patient well, you will not face this crisis. What's the meaning of this crisis? This occurs in the thyroid causes if you are performing thyroidectomy without proper preoperative preparation, and so the presence of the surgical stress for the patient, together with the manipulation of the thyroid, it will release a large amount of T3 and T4 inside the blood or the circulation of the patient, leading to significant clinical manifestation in the form of convulsions, hyperpyrexia, extensive sweating, severe palpitation, up to cardiac arrest. And so, how to treat with it? Number one, we have most important to prevent it. How to prevent the thyrotoxic crisis? Proper preoperative preparation. But how to deal with it post-operative? Mostly symptomatic. Yani we have convulsions, and so I should give to the patient anticonvulsant. We have severe palpitation. I will give the patient parenteral beta blocker. We have hyperpyrexia, ice bath, and antipyretics. And I will give antithyroid medications to the patient to try to control the patient condition. Keloid could be frequently seen. وانتوا عارفين what means keloid؟ yes بالهوي. هذا السكار. اوكي طب what's the difference between keloid and hypertrophic scar؟ X تمام ان الهايبرتروفيك سكار is widening of the scar but it's limited to the scar. If we have a hyperperforation of the fibrous tissue extending beyond the side of the scar, this is the keloid. And so, is the keloid common in the thyroidectomy? Mostly not. By the way, thyroidectomy is performed through a collar incision. Collar incision is a low cervical transverse incision to respect the what we call the Langer's line, which is the creases. Yani all of the cosmetic surgical interventions is performed through certain creases, like the cesarean section. Cesarean section, very old ago, was performed through lower abdominal longitudinal incision, infra-umbilical incision. Like currently, it becomes through what we call Finisteel incision, which is a lower abdominal transverse incision in the bikini line to be more cosmetically accepted. Also, the collar incision is performed to respect the Langer's line, which is the creases. And so, let's say that this incision is performed lower down over the manubrium sternum. Any scar over the pool is having a very high tendency to perform keloid. Hypothyroidism, if you are performing total without post-operative replacement. Recurrent hyperthyroidism, if you are performing subtotal. By the way, I mentioned it before, but just to memorize you. If you are performing subtotal, you should give the patient post-operative L-troxin. It's not only to replace. Maybe the part that you are keeping is enough to replace the normal amount of T3 and T4. It's called suppressive dose. What's the meaning of suppressive dose? You are suppressing TSH to prevent the recurrence of the These are the causes of respiratory obstruction that could be present after the operation, like hemorrhage. And we mentioned that if we have hemorrhage, or which type of hemorrhage could be associated with respiratory obstruction? Reactionary. And if we have reactionary hemorrhage together with respiratory stress or respiratory obstruction, what is the initial line? I should remove all of the suture before entering the OR. Laryngeal edema due to the over dissection over the isthmus by diathermy and cautery and so on, we may have laryngeal edema. Recurrent laryngeal nerve injury. Which type of recurrent laryngeal nerve injury will lead to stridor? Partial. Bilateral. Injury to trachea could also lead to respiratory brainstorming. Another critical question: what's the first vessel to be ligated during thyroidectomy? Middle thyroid. Why? Shortest. We have superior thyroid vessels, inferior thyroid vessels. Do we have middle thyroid vessels? It should be vein, صح كده؟ طيب. There's no choices here. It's very important. It's very important and direct. A middle-aged male patient presents with secondary toxicity. She underwent thyroidectomy. Post-operative, she developed high-grade fever, tachycardia, and convulsions. What's the most important appropriate diagnosis? Thyroid crisis. A 40-year-old male patient underwent total thyroidectomy for treatment of cancer thyroid. Post-operative, the patient developed aphonia. What type of recurrent laryngeal nerve injury is responsible for this condition?
Bilateral complex.
Aphonia يبقى bilateral complex. Okay, thank you all. Inshallah, we'll meet after the prayer.